Myocardial infarction, an acute coronary syndrome, results from reduced blood flow through one of the coronary arteries. This causes myocardial ischemia, injury, and necrosis. ACS is an umbrella term that covers a range of thrombotic coronary artery diseases, including unstable angina, ST elevation myocardial infarction and non-ST elevation myocardial infarction. In North America and Western Europe, MI is one of the leading causes of death. Death usually results from cardiac damage or complications. Men are more susceptible to MI than premenopausal women, although the incidence is increasing in women who smoke and take hormonal contraceptives. In myocardial infarction, blood supply to the myocardium is interrupted. Here's what happens. Injury to the endothelial lining of the coronary arteries causes platelets, white blood cells, fibrin, and lipids to converge at the injured site. Foam cells, or resident macrophages, gather under the damaged lining and absorb oxidized cholesterol, forming a fatty streak that narrows the arterial lumen. Because the arterial lumen narrows gradually, collateral circulation develops in which arteries grow to make a natural bypass towards an area of reduced blood flow and helps maintain myocardial perfusion distal to the obstruction. During this stage, the patient may have chest pain when myocardial oxygen demand increases. When myocardial demand for oxygen is more than the collateral circulation can supply, myocardial metabolism shifts from aerobic to anaerobic, producing lactic acid, represented by A, which stimulates nerve endings. The patient experiences worsening angina that requires rest and medication for relief. Lacking oxygen, the myocardial cells die. This decreases contractility, stroke volume, and blood pressure. The patient experiences tachycardia, hypotension, diminished heart sounds, cyanosis, tachypnea, and poor perfusion to vital organs. Hypoperfusion stimulates baroreceptors, which in turn stimulate the adrenal glands to release epinephrine and norepinephrine. These catecholamine represented as C increase heart rate and cause peripheral vasoconstriction, further increasing myocardial oxygen demand. The patient may experience tachyarrhythmias, changes in pulses, decreased level of consciousness, and cold, clammy skin. Damaged cell membranes in the infarcted area allow intracellular contents into the vascular circulation. Ventricular arrhythmias then develop with elevated serum levels of potassium, creatine kinase, CK, and CKMB, and troponin. All myocardial cells are capable of spontaneous depolarization and repolarization, so the electrical conduction system may be affected by infarct, injury, and ischemia. The patient may have a fever, leukocytosis, tachycardia, and electrocardiogram signs of tissue ischemia, injured tissue, and infarcted tissue. Extensive damage to the left ventricle may impair its ability to pump, allowing blood to back up into the left atrium and, eventually, into the pulmonary veins and capillaries. When this occurs, the patient may be dyspneic, orthopneic, tachypneic, and cyanotic. Crackles may be heard in the lungs on auscultation. Pulmonary artery pressure and pulmonary artery wedge pressure are increased. As back pressure rises, fluid crosses the alveolo-capillary membrane, impeding diffusion of oxygen and carbon dioxide. Arterial blood gas measurements may show decreased partial pressure of arterial oxygen and arterial pH and increased partial pressure of arterial carbon dioxide. In patients with coronary artery diseases, angina may signal an impending infarction. Other clinical effects that occur during an MI include fatigue, nausea, vomiting, shortness of breath, cool extremities, and diaphoresis. Fever is unusual at the onset of an MI, but a low-grade temperature may develop during the next few days. Myocardial infarction results from occlusion of one or more of the coronary arteries. Occlusion can stem from atherosclerosis, thrombosis, platelet aggregation, or coronary artery stenosis or spasm. Predisposing factors include elevated serum triglyceride, low-density lipoprotein, cholesterol, and homocysteine levels. Excessive intake of saturated fats, carbohydrates, or salt. As well as hypertension, obesity, and a positive family history of coronary artery disease. Smoking, stress, use of amphetamines or cocaine are also known to increase risk of myocardial infarction. Susceptibility increases with age. Like elderly patients, they are more prone to complications and death. The most common complications after an acute MI include arrhythmias or uneven heartbeat, cardiogenic shock when the heart cannot pump enough blood and oxygen to the brain, kidneys, and other vital organs. Lastly is heart failure causing pulmonary edema and pericarditis. Myocardial infarction results from prolonged ischemia to the myocardium with irreversible cell damage and muscle death. Functionally, MI causes reduced contractility with abnormal wall motion, altered left ventricular compliance, reduced stroke volume, reduced ejection fraction, and elevated left ventricular and diastolic pressure. Tissue regeneration doesn't occur after an MI because the affected myocardial muscle is dead. However, scar tissue forms on the necrotic area and may inhibit contractility. When this occurs, the compensatory mechanisms such as vascular constriction, increased heart rate, and renal retention of sodium and water can kick in to try to maintain cardiac output. Ventricular dilation also may occur. If a lot of scar tissue forms, contractility may be greatly reduced, leading patient to develop heart failure or cardiogenic shock. To help diagnose myocardial infarction, tests include serial 12-lead ECG during the first few hours after an MI. Serial 12-lead ECG may be normal or inconclusive. Serum creatine kinase levels are elevated, especially the CKMB isoenzyme, the cardiac muscle fraction of CK troponin 1, a structural protein found in cardiac muscle, is elevated. Troponin levels increase within 4 to 6 hours of myocardial injury. Myoglobin is released with cardiac muscle damage and elevated levels may be detected. And lastly, echocardiography shows ventricular wall dyskinesia with ischemia and is used to evaluate the ejection fraction. Drugs are the mainstay of therapy. Typical drugs include thrombolytic agents, such as tissue plasminogen activator and streptokinase to revascularize myocardial tissue. Procainamide or another antiarrhythmic, such as lidocaine or amiodarone. Glycoprotein inhibitors such as abciximab or aspirin to minimize platelet aggregation. Intravenous administration of atropine for heart block or bradycardia. And intravenous administration morphine for pain and sedation. Lastly is angiotensin-converting enzyme inhibitor to reduce afterload and preload and prevent remodeling. Other therapies include temporary pacemaker for heart block or bradycardia. Oxygen administered by face mask or nasal cannula is also important. And bed rest with bedside commode to decrease cardiac workload. As well as cardiac catheterization, percutaneous transluminal coronary angioplasty, stent placement, and coronary artery bypass grafting.